Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some useful tips that you may find handy in your line of duty. So I welcome you to part 94 of our pharmacotherapy MCQ series, which majors in basic oncology. And the first question reads, Mrs. ORM, a 43-year-old female patient with confirmed early-stage breast cancer, receives a mastectomy. She is almost completing her adjuvant chemotherapy regimen. She inquires from you, as the oncology clinical pharmacy specialist, about adjuvant hormonal therapy. So my question to you is, which of the statements listed below is true regarding adjuvant tamoxifen therapy for breast cancer patients? Is it true that estrogen-resistant patients may still benefit? Or is it true that premenopausal patients don't benefit from tamoxifen? Or is it true that high-risk patients who received 5 years of adjuvant tamoxifen may benefit from an additional 5 years of adjuvant endocrine treatment? Or is it true that, considering her early-stage breast cancer, 2 to 3 years of adjuvant endocrine treatment may be adequate for Mrs. ORM? I'll give you 10 seconds to choose the correct answer. It is true that high-risk patients who receive 5 years of adjuvant tamoxifen may benefit from an additional 5 years of adjuvant endocrine treatment. Now, new studies have shown that patients at a higher risk of recurrence who have been treated with tamoxifen for 5 years should consider extended tamoxifen for an additional 5 years to complete a total of 10 years. Now, 2 to 3 years of adjuvant tamoxifen is inadequate. And I would like to add that aromatase inhibitors are preferred in postmenopausal women compared with tamoxifen, but tamoxifen remains the standard of care for premenopausal patients. Now, tamoxifen hasn't been shown to have utility in estrogen resistant negative or progesterone resistant negative breast cancer cases. Now, adjuvant chemotherapy and endocrine therapy should be given sequentially, with endocrine therapy following chemotherapy. That is clearly stated in the NCCN guidelines. Let's move to the next question, please. And it reads, your oncology team plans to initiate Etoposide as a transplant preparative regimen for P.L.R, a middle-aged patient. Now, my question to you is, which of the following would you expect to occur as the primary non-myeloablative dose-limiting toxicity in this clinical scenario? Would it be neurotoxicity, mucositis, pulmonary fibrosis, or hemorrhagic cystitis? I'll give you 10 seconds to choose the correct answer. Mucositis it would be. Now, Etoposide's primary non-myeloablative adverse effect is mucositis. I would like to remind you that cytarabine is well known to produce various events including cerebellar ataxia and dysarthria. Then hemorrhagic cystitis and cardiotoxicity are seen with high-dose cyclophosphamide, and pulmonary fibrosis may be seen with cremostin or busulfan. So all those many words make mucositis the best answer to that question. Let's move to the next question, please. And it reads, as the oncology clinical pharmacy specialist in your oncology team, you are responsible for writing a new policy and procedure guideline for the prevention of chemotherapy extravasation. So my question to you is, which of the statements below would be your recommendation? Is it A, sites including joint spaces should always be used for vesicant administration? Or is it B, repeat venipunctures should be distal to the previous injection site? Or is it C, always administer vesicants as IV push if administered peripherally? Or is it D, peripheral lines should be used whenever possible for vesicant administration? I'll give you 10 seconds to choose the correct answer. So always administer vesicants as IV push if administered peripherally, and I'll explain why. Now, if vesicants are being administered peripherally, close monitoring is required. And remember, vesicants administered IV push will allow continuous monitoring by the nursing staff, and this option should be considered when a central line isn't readily available and you are administering a vesicant. I would like to underscore the fact that repeat venipuncture distal to the previous site may cause the patient's increased risk of extravasation, so I would not opt for B. And I would like to remind you that chemotherapy should be administered IV, not at joints. So that makes alternative A wrong. And remember, chemotherapy should ideally be administered via central line to reduce the risks of extravasation. However, if given peripherally, vesicant chemotherapy should be administered via IV push to allow for continuous monitoring by the nursing staff, as I mentioned earlier. Now, in the management of chemotherapy extravasation, local cooling is recommended for DNA binding vesicants, whereas local warming is recommended for non-DNA binding vesicants. Just remember those small bits when you're managing extravasation, when it inevitably occurs. Let's move to the next question, please. And it reads, your medical oncologist used the Gale model and predicted 4% risk of breast cancer in a 60-year-old postmenopausal female patient with an intact uterus. This lady has a past medical history of type 2 diabetes mellitus. She's hypertensive, she suffers from hypothyroidism, and she has a history of VTE. So my question to you is, which of the agents listed below would be the most appropriate for breast cancer prevention in this patient's clinical case or scenario? Would it be tamoxifen, naloxone, anastrozole, or none of the above three agents? I'll give you 10 seconds to choose the correct answer. Anastrozole it would be. Now, according to the NCCN guidelines, postmenopausal patients desiring risk reduction therapy may use either tamoxifen, raloxifene, or exemestane. Now, although aromatase inhibitors aren't FDA approved for this indication and insurances may not cover them as medications, they are listed as one of the two Category 1 recommendations for postmenopausal women other than tamoxifen. Now, the two aromatase inhibitors that have been studied for risk reduction are anastrozole 1 mg orally once a day and exemestane 24 mg orally once a day. Unfortunately, there is no data comparing the benefits and risks of exemestane and anastrozole to those of tamoxifen and raloxifene. Now, the side effects typically associated with the aromatase inhibitors include, for example, hot flashes, musculoskeletal events, arthralgias, vaginal dryness, osteoporosis, arthritis, and not thromboembolic events, which makes anastrozole the best option for this patient based on her history of VTE. Remember, it's mentioned in the text above. Now, if aromatase inhibitors weren't an option, then raloxifene would be preferred over tamoxifen, since this patient has an intact uterus plus a history of VTE. Remember, tamoxifen can increase the risk of endometrial cancer and thromboembolism. Now, according to the breast cancer prevention trial, those patients with the hypercoagulable state, such as factor V Leiden, warrant at an increased risk of clots, and patients should still be cancelled on the risk and symptoms of thromboembolism with tamoxifen. Now, raloxifene wouldn't increase these patients' risks of cancer or clot, just to remind you. Let's move to the next question, please. And it reads, which of the agents listed below is well known for causing pulmonary toxicity in oncology patients? Is it topotecan, etoposide, bleomycin, or doxorubicin? I'll give you 10 seconds to choose the correct answer. Bleomycin C is the correct answer. Now, just like to comment that pulmonary toxicities seen from bleomycin majorly include pulmonary fibrosis. So that makes it the correct answer to this question. Let's move to the next question, please. Our next question reads, Mr. DMT, a 69-year-old male patient with confirmed non-small cell lung cancer, presents to your medical oncologist complaining of heartburn and stomach pains. Mr. DMT denies any black or bloody stools. He neither has nausea nor vomiting. He currently takes erlotinib, and he has stable pain, which he relieves with NSAIDs alongside morphine. So my question to you is, which therapeutic option listed below would be the most appropriate for this suspected NSAID-induced gastritis? Would you choose to continue NSAID and initiate omeprazole therapy? Would you opt to continue NSAIDs and start ranitidine, an H2 receptor blocker? Or would you stop NSAID and begin antacids containing aluminum hydroxide and magnesium hydroxide? Or would you stop NSAID therapy and begin cimetidine? I'll give you 10 seconds to choose the correct answer. Stop NSAID therapy and begin the antacid therapy. Now, stopping NSAIDs will be the most appropriate initial therapy for Mr. DMT. And I would like to add that PPIs and H2 blockers will be more effective than antacids for gastritis, but will potentially decrease the pH-dependent absorption of erlotinib, which is very crucial and key in its therapy. Now, antacids, on the other hand, do not significantly alter gastric pH, so this interaction with erlotinib is unlikely. I'd like to point to the fact that the package insert for erlotinib recommends giving erlotinib 10 hours after the H2 blockers and at least 2 hours before the next dose of H2 blockers. Now, cimetidine could be administered in that fashion, but it is not desirable due to a drug-drug interaction that would occur between it and erlotinib. Remember, cimetidine is a CYP3A4 inhibitor, and CYP3A4 is required for erlotinib metabolism. So never ever co-administer the two. Let's move to the next question. And it reads, at what hemoglobin level should erythropoiesis stimulating agents, abbreviated as ESS, such as Epoetin and Darbepoetin alpha, be used for chemotherapy-induced anemia? Is it at 12 to 14 grams per deciliter, or 11 to 12 grams per deciliter, or below the 10 grams per deciliter mark, or 10 to 11 grams per deciliter? I'll give you 10 seconds to choose the correct answer. So the correct answer would be below the 10 grams per deciliter mark. Now, these agents shouldn't be initiated until the HB level is less than 10 grams per deciliter. Now, further restrictions include the chemotherapy duration needs to be 2 months or longer, and that the patient isn't a curative intent. The goal of therapy is to minimize the need for red blood cell transfusion with the smallest ESA dose. Let's move to the next question, please. And it reads, Mrs. DAO, a 60-year-old female patient with confirmed breast cancer, has been initiated on AC, which is doxorubicin, co-administered with cyclophosphamide by your oncologist, your medical oncologist. She has a past medical history of morning sickness with her multiple pregnancies. She smokes 1 packet of cigarettes per day, and she's been doing that for 30 years. She drinks a glass of wine weekly. So my question to you is, which risk factors for chemotherapy-induced nausea does Mrs. DAO have? Is it older age, history of morning sickness and heavy tobacco use? Is it female gender, AC chemotherapy and low alcohol use? Is it older age, female gender and AC chemotherapy regimen? Or is it older age, history of morning sickness and heavy tobacco use? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Female gender, AC chemotherapy and low alcohol use. Remember, the risk factors for acute nausea and vomiting is higher in younger age, that is below the age of 50 in females. Now, younger women with breast cancer receiving chemotherapy, low alcohol use, history of motion sickness, and a history of morning sickness can also be risk factors. Other factors, in my opinion, include a history of nausea and vomiting, the environment in which the chemotherapy is infused, and even the dose or the efficacy of the hematogenic regimen administered. And I would just like to remind you that the AC chemotherapy regimen is considered highly hematogenic. That is to say, over 90% of patients receiving it experience emesis. Now, older age and tobacco use aren't considered risk factors for acute nausea and vomiting. And the main neurotransmitter involved in emesis are serotonin, which is 5-HT3, and dopamine. That's just for your information. Now, other neurotransmitters include, to a smaller extent, acetylcholine, corticosteroids, histamine, cannabinoid, opioids, and even the neurokinin 1, abbreviated as NK1. Now, antiemetic agents work in various ways by targeting these receptors that I've just listed. So let's move to the next slide, please. And the question reads, your oncology team decides to treat Mr. ZOK, a 58-year-old male patient with confirmed metastatic renal cell carcinoma, RCC, with pazopanib. My question to you is, which of the receptors listed below isn't a target of pazopanib? Is it the C-KIT? Is it the VEGFR? Is it the EGFR? Or is it the platelet-derived growth factor receptor? I'll give you 10 seconds to choose the correct answer. So C is the correct answer, the EGFR. I would like to start by saying that pazopanib, that limits tumor growth by targeting angiogenesis via inhibition of VEGFR. It also does so by inhibiting the platelet-derived growth factor receptor and even the c-KIT, but it doesn't inhibit EGFR. Now, drugs that inhibit VEGFR include bevacizumab, ramucirumab, sorafenib, and they are commonly associated with hypertension. So blood pressure should be monitored during therapy using such agents, just as a by the way. Let's move to the next question, please. And the next question reads, your oncology team is currently treating patients with prostate cancer. So my question to you is, which of the following is the most appropriate endpoint for a new antineoplastic in prostate cancer? Is it A, time to progression, or B, response rate, or C, overall survival, or is it D, progression-free survival? I'll give you 10 seconds to choose the correct answer. Overall survival is the correct answer. Now remember, progression-free survival is a promising secondary endpoint, but unfortunately it isn't the most appropriate primary endpoint for prostate cancer. Now, since this disease state is relatively chemotherapy resistant, there will be less interferences with future therapies after the patient progresses after the investigational agent. Now, this characteristic will allow overall survival to be the most relevant and appropriate endpoint. Let's move to the next question, please. And it reads, chemotherapy vesicants, which cause tissue damage by DNA binding, tend to cause severe and prolonged skin toxicity. My question 2 is, which of the agents listed below causes tissue destruction by DNA binding when extravasation occurs? Is it bevacizumab, docetaxel, daunorubicin, or vinblastine? I'll give you 10 seconds to choose the correct answer. Daunorubicin it is. I would like to start by saying that vesicant chemotherapy agents can be categorized as DNA binding, that is the alkylating agents, anthracyclines, actinomycin, mitomycin, mitoxantrone, all fall in that category. And then there are the non-DNA binding, which includes the vinca alkaloids and tangzines. Now, compared to DNA binding vesicants, the non-DNA binding vesicants are eventually metabolized by the tissue into which they extravasate and are more easily neutralized. Now, daunorubicin causes tissue damage by DNA binding when extravasated. Now, although dexrazoxane, which is marketed as Zinecard, has been used for many years to reduce anthracycline-induced cardiotoxicity, the FDA eventually approved it in 2007 to be specific, for the treatment of anthracycline extravasation. Just for your information, let's move to the next question, please. Which reads, Mrs. IFT, a 45-year-old female patient, is undergoing chemotherapy at the oncology clinic. She experienced a significant amount of nausea and vomiting after her first cycle. 48 hours ago, she called your medical oncologist expressing her anxiety about her upcoming second chemotherapy cycle. The oncologist suggested a pre-medication before the second cycle. So my question to you is, which of the medications listed below is Mrs. IFT likely to receive prior to her second cycle of chemotherapy? It be promethazine, hydroxyzine, lorazepam, or prednisone? I'll give you 10 seconds to choose the correct answer. Lorazepam it will be. Now, Mrs. IFT is most likely experiencing anticipatory nausea and vomiting, since the case reports she had experienced a significant amount of nausea and vomiting after the first cycle of her chemotherapy, and is now expressing anxiety about the upcoming treatment, which will be the second cycle to be precise. Now, benzodiazepines such as alprazolam, diazepam, and lorazepam are the drugs of choice to help reduce and even treat anticipatory nausea and vomiting. Note the other agents listed there, that is promethazine, hydroxyzine, and prednisone. Now, all benzodiazepines are contraindicated in pregnancy, so avoid them if such a patient were pregnant. There you have it, my highly esteemed viewers and listeners. That brings us to the very end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave your comments at the very bottom. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in part 95 of our pharmacotherapy MCQ series. Thank you.